Hi everyone. So today we're going to be covering the elbow, the upper arm, the forearm, the wrist, and the hand. So I'm going to separate these into two videos. The first is going to be the upper arm, elbow, and the forearm, and then the second is going to be the wrist and hand. There's going to be two separate slides that go with these as well to kind of help break up those things for you. It is a lot of information, but not as many injuries as we had with the shoulder. And so we'll get started on elbow, upper arm, and forearm. So slide 2, we're looking at anatomy of the elbow. So we start with the humeral ulnar joint, which is a hinge joint at the elbow. And this is the articulation of the trochlea of the humerus with the reciprocally shaped trochlear fossa of the ulna. The motions that happen here are flexion and extension of the elbow. Next, we have the humeral radial joint. This is lateral to the humeral ulnar joint, and it is formed between the spherical capitulum of the humerus and the proximal radius. This joint is a gliding joint. Next, we have the proximal radio-ulnar joint, and this is where the annular ligament binds the head of the radius to the radial notch of the ulna. This is a pivot joint, and this is where we see pronation and supination happening. On slide 3, we talk about the major ligaments of the elbow. So these are what we're going to be focusing on with injuries and such throughout these slides. The ulnar collateral ligament, the annular ligament, the lateral ulnar collateral ligament, and the radial collateral ligament. And so there's a picture on the slides for you that shows where all of those ligaments are in their respective places in the elbow. On slide 4, we're looking at muscles of the arm and forearm. A large number of muscles cross the elbow, and so they go from the upper arm to the forearm, and they're crossing there. Major muscles are shown on the slide for you, and so just knowing those, it's a good reference point. When it comes to the forearm, there's a lot of tiny intrinsic muscles that are happening there, and so knowing all of them specifically is not always necessary. And so just knowing an idea of what you're dealing with, pronators, supinators, things like that, what action of the muscle is injured is important, and then later on you can go back and maybe look up which muscle specifically. I know for me that's something that's helpful, is knowing that I can always go back and do that, because knowing every single one is pretty difficult, and knowing all of the actions and everything for those. Especially with a joint where it crosses, or with a muscle that crosses the joint, you have to take into account what is the angle of the shoulder, what is the angle of the elbow, and all of those things. And so it is okay to not memorize all of these muscles right now. So that's why that picture is on the slide for you, on slide 4, because then you can go back and reference what muscles we're talking about here. Other anatomy, we're talking about the bursa. So one of the big injuries we're going to look at is occurs at the subcutaneous olecranon bursa, and so it's important to know where that bursa sits. And then we're looking at nerves. These nerves descend from the brachial plexus, and they include the musculocutaneous nerve, the median nerve, the ulnar nerve, and the radial nerve. And those will be important when we talk about function of the hand and the wrist and the fingers, if there's numbness and tingling, how to determine which nerve might be involved. All right, so kinematics and major muscle actions of the elbow. Let me find my spot here. Sorry. Here we go. So the three associated joints at the elbow allow motion in two planes. So flexion and extension are sagittal plane movements that occur at the humeral ulnar and humeral radial joints. And then pronation and supination are longitudinal rotational movements that take place at the proximal radial ulnar joint. And so the elbow, we don't have a ton of motion here. We're going extension, and flexion, and that is all that we're going to get. Some people do have some hyperextension naturally in their elbow, and so they'll have a little bit of extra motion there. Hyperextension is one of the injury mechanisms that we're going to look at, but for the most part, we're looking at flexion, extension and flexion of the elbow, and then we're also looking at pronation and supination of the forearm. All right, so let's get into some injuries. On slide 7, we have, we're going to start looking at contusions. So direct blows to the arm and forearm are frequently associated with contact and collision sports. Contusions result from a compressive force sustained from a direct blow, and those injuries vary in severity according to the area and the depth over which the blood vessels are ruptured. Contusions occur more frequently over bony prominences. So signs and symptoms that we're looking for here are ecchymosis. It might be present if the hemorrhage is superficial. Significant trauma can lead to internal hemorrhage, rapid swelling, and hematoma formation that can limit range of motion. Chronic blows to the anterior arm can result in the development of ectopic bone in either the belly of the muscle or as a bony outgrowth. And so in one of the pictures, the only picture on the slide here is showing a growth in that muscle, and that is what we call myositis ossificans. It's a calcium deposit in the belly of the muscle from chronic or repetitive blows. The body is responding to those blows, and the muscle can't take as much anymore, and so it's depositing calcium as a defense mechanism, and then you start to develop a bony prominence in the belly of the muscle. So we want to avoid that at all costs. Let's see what is next. Management of these: ice, compression, and then protection. With a contusion, ice is always what we want to do first. We want to intervene with that inflammatory process, and so icing and elevating is going to be what we want to do first. Activity modification, because we don't want them to continually get hit. So like if you have a bruise on your upper arm, it's totally fine to keep playing, but we want to protect that with maybe some padding or something so that you're not continuously getting hit, and then that calcium deposit will start happening. And so you can use NSAIDs to decrease swelling and pain, and then you'll work on active range of motion and stretching as well. On slide 8, we have olecranon bursitis. So this one, what I talked about before, we're involving the subcutaneous olecranon bursa. And so this can be acute or chronic. A fall on a flexed elbow is acute. And so if you fall out this way, or if you run into the wall or whack something with that elbow, that will be an acute mechanism of injury. Leaning on your elbow, sitting like this, repetitive pressure or friction on that olecranon process is chronic. That can also cause olecranon bursitis. So signs and symptoms. If you look at the picture on the bottom, you can see immediate swelling and redness. It's going to be very tender as well. Sometimes motion is limited at the end of extension and flexion. They might not be able to go all the way due to pain. Management here is ice, compression, and rest. If this happens in the middle of a soccer game, let's say, and it will swell immediately, you can wrap that up and they can keep playing. It's not going to inhibit them or harm them at all. But once they're all done, you want to ice and compress and then rest, letting that swelling go down. Sometimes it will require the doctor to remove some of that fluid or do an aspiration. And then other times a corticosteroid injection can be performed to keep the inflammation down. There's also septic and non-septic bursitis. Septic bursitis is related to an infection at a distal site, and non-septic bursitis can be caused by crystalline deposition, disease, or rheumatoid involvement. And so the septic and non-septic we don't necessarily see a ton in athletics, but the acute and chronic we do see, and that is how we would manage those things. I've seen it once in a soccer player, and he, like I said, it blew up immediately. He continued playing. He tried to hide it during the game because he didn't want me to take him out, but I wouldn't have taken him out anyway. And then just working on the opening up the lymphatic channels. You can use KT tape, but mostly using ice and compression to get that inflammation down. Slide 9, we're looking at collateral ligament sprain. Again, so sprain here, we're talking ligaments. And here is one of the most common elbow sprains. It's an acute tear to the ligament and joint structures at the elbow. Injuries occur during a fall on an extended hand, so that foosh mechanism that we talked about in the shoulder. It can happen in elbow hyperextension or through a valgus or varus tensile force. More commonly, though, repetitive tensile forces will irritate and tear the ligaments, particularly the UCL or the ulnar collateral ligament. And then if the UCL is damaged, the ulnar nerve can also be affected. So signs and symptoms here is a history of pain localized to the medial aspect of the elbow. Examination reveals point tenderness on the joint line, as well as increased pain and instability with the valgus stress test applied to the elbow at 15 to 20 degrees of flexion. Treatment involves standard acute care with ice, compression, and protection for rest. Brief immobilization might be necessary in some acute cases, and then protected range of motion exercises to stretch the forearm. If there is laxity with that valgus stress test, though, we would refer to a physician to get imaging. They could have torn the UCL, and that will be a surgical repair. That one is very well known as the Tommy John surgery, and so that's the picture that I have on the slide there to reinforce that UCL surgically. All right, sprains to the elbow. We are looking at, other sprains. So anterior capsulitis is caused by hyperextension, and they'll have anterior joint pain. Symptoms are diffuse anterior elbow pain, which can be accompanied by deep tenderness upon palpation. You'll do some manual muscle testing to rule out a strain here, but more than likely you're going to have both, a sprain and a strain. Management, immobilization for 3 to 5 days, and then range of motion exercises and rehabilitation to follow up. Elbow dislocations are fairly uncommon, but they do happen, and so falling on that outstretched hand you see in the picture, falling backwards or falling forwards, you can dislocate in 2 ways there. So dislocation of the radius and ulna joint, or dislocation of the humerus and ulnar joint. So knowing the difference between those, always refer to the emergency room when there's an elbow dislocation. I've never seen one in person, but you would refer, it has to be reset by a doctor, and you need imaging because there's more than likely fracture or a tear that's happening as well. All right, so strains. We're looking at flexor and extensor strains. Those occur from an inadequate warm-up, excessive training, or inadequate rehabilitation. Signs and symptoms would be palpable muscle pain over the involved muscle mass. Pain increases with active and resisted range of motion, and the muscle spasm or guarding may occur. On the next slide, we're going to talk about management of strains, so they're going to be all fairly similar. In the shoulder, we talked about the rupture of biceps brachii, so here we're just going to go over it again. 97% of these strains are proximal, so they occur up at the top. Proximal, up at the top. Due to pre-existing degenerative disease, we talked about steroid use is a big one, and then injections make the muscle more vulnerable to tear. As you see in the picture on the left-hand side, the belly will retract. We talked about that before, and it will make a bulge at the proximal end of the bicep. You'll feel deficit at the distal end, and then the patient will be able to flex their elbow, but the movement will be weak, and they will not be able to resist. On the other side, we are looking at rupture of triceps brachii, which is caused by a direct blow to the elbow. More than likely not a foosh injury. And then 80% of these tricep ruptures involve an avulsion fracture as well, which is what you're seeing in the x-ray picture on the slide. The tricep has avulsed from the elbow. Signs and symptoms here are pain and swelling of the olecranon process, a palpable defect, and then active extension might be weak and won't be able to be resisted. So on slide 12, I outlined management of muscular strains for you. So you can go through and one by one, in order of how you would manage these strains. This can be applied to strains in the entire body. And so we've talked a little bit about strains in all the other slides. And so this will just be something you guys can refer back to for all muscle strains that we're dealing with from here on out. So that will be there for you to look at. We don't necessarily have to go over all of it. We've talked about all of them in pieces, but that's just a reference for you, 9 steps to managing a muscular strain. On slide 13, we have overuse injuries. The elbow is very common for overuse injuries. And so we're going to go through those right now. You hear words like tennis elbow or golfer's elbow, and that's what we're looking at here. So during a lot of sports, you're using, or in the overhead sports with throwing, we talked about water polo being right here. Gymnastics is a big one. Tennis, golf, baseball, volleyball, lots of overuse injuries that can occur. So first one is medial epicondylitis. And so we're talking about the inside of the elbow. I know through my sweater you can't see a ton, but the medial side of the elbow. So injury occurs when valgus forces produce a combined flexor muscle strain with ulnar collateral ligament sprain and ulnar neuritis. And so this medial complex of the elbow, the integrity has been compromised and it's wearing out. It is used too much. The muscles are not strong enough, and so it's causing epicondylitis and some inflammation there because it's working really hard. Signs and symptoms are swelling, ecchymosis, and point tenderness. Pain is usually severe over the medial epicondyle, but athletes will be able to play through this. More than likely, that's why they get injured, because they keep playing, even when there's a little bit of pain, and then it gets worse and worse, and then it gets to the point where it's too much pain and they can't keep going. Excuse me. Then we look at the lateral side, and we have lateral epicondylitis, which is caused by eccentric loading to the exterior or the extensor muscles during the deceleration phase of the throwing motion or a tennis stroke. So we're on the outside of the elbow now, and pain is anterior or just distal to the lateral epicondyle, and it might radiate into the forearm extensors during activity. Pain with this becomes severe with more and more repetition. So again, the athlete has played with this for a long time, over and over, repetitive forces, keep doing the same thing, and then pain is getting worse. Management for both of these would be ice and rest. With any overuse injury, ice and rest. Sometimes if an athlete needs to keep going, I will give them a compression sleeve, and that will help. There's also a little strap that we can put on here. It's called a show pat, and it will kind of change the angle of the muscle, and it will sometimes alleviate pain there too. But then it's also a telltale that you need to strengthen the surrounding muscles, and so tubing and exercises are important to start at this point as well. All right, so like I talked about in shoulder, we're not going to go over the first part of assessment anymore, so we're going to go right into palpation. So here we have a lot of structures to palpate: anteriorly, laterally, posteriorly, and medially. So again, you can do this on yourself, because now we're at the elbow, so you can sit and kind of just palpate around on your own, following the list that I gave you on the slide, and finding those different structures and what a normal one would feel like. Active range of motion at the elbow on slide 15. So the picture shows you A, B, and C, flexion, supination, and pronation, and then how you would use the goniometer to measure those. For flexion, you would measure extension the same way, and then you can also do the wrist in this case as well. I also gave you normal ranges for each motion, and so knowing those is going to be important too. On slide 16, we talk about passive movements and resisted muscle testing. So passive movements, we talked in the shoulder about what is stopping those motions from happening, whether it's a bony end feel or a tissue end feel, and what that means. And so at the elbow flexion is here. So this is a tissue stretch here. This is preventing me from going any further. Tissue approximation, we talked before, is shoulder adduction. And then bone to bone would be elbow extension. So my olecranon process is hitting here, and so that's why I can't go any further. It's not because my bicep is tight, it is because of this bone to bone in the back. And then resisted muscle testing, those pictures on the slide is showing how to perform resisted muscle testing. So A is elbow flexion, B is elbow extension, C is forearm supination, D is forearm pronation, E is wrist flexion, and F is wrist extension. So that's showing how the patient and you as the clinician should be positioned to do all of those things. So then we're moving on to stress tests and how to eliminate injuries in the elbow, or eliminate our differential diagnosis. These are difficult to get an accurate assessment in the elbow with a valgus or varus stress test. Because of that, these tests need to be performed at different angles. And then when the olecranon is unlocked from the olecranon fossa, that's when the ligament structures are isolated. So doing these tests in full extension and then also from 20 to 30 degrees will help kind of give you more of an idea of what you're looking at. So to test the UCL, the patient is seated and their arm is extended and stabilized. So you as a clinician would stand behind and stabilize their arm. So I have my little dummy here. I'll see if I can use this to show you guys. So my patient is here. So I want to test the elbow. So take this off. There we go. So what I will do is my patient is seated and I want to test their elbow, valgus, and varus. This guy doesn't bend, but you'll get the idea. So what I'll do is I'll actually come in and I'll take their arm and I will pin their hand kind of under my armpit against the body, and it makes them more comfortable. They know that they can relax, their arm's not going to fall down, and I have control of their arm. And then I will take, well, this guy is not stable up here, so it's going to be a little more difficult. So then I will hold their arm and I'll hold here. And then I am testing outside, which will be varus. This is testing the radial collateral ligament. So then I'm pushing, just some stress right on the joint line. See how my hand is over the joint there. And I'm pushing just a little bit to stress this outside. And then exact same thing on the other side. So I'll pin their arm, I'll hold it down here, and then I'm going to be pushing on this joint line up here and stressing. So we're looking for laxity in this, and then we're looking for pain. So if there is no UCL, they'll have pain, and you'll feel that there's no end feel there, and you'll feel the laxity of the joint kind of opening when you're doing that stress test. Special tests, we are looking at the common extensor tendinitis test, medial epicondylitis test, Tinel's sign for ulnar neuritis. So that is the top picture that we see. You'll take their arm, you're looking for numbness and tingling in the hand, and so my bony prominence is right here. And so we're gonna tap right in here. This is where the ulnar nerve runs through. You can feel kind of a divot, and they'll be tapping right in there, trying to elicit a numbness and tingling that they will feel down in the pinky. And then one of the ones that I really like is the pinch grip test. And so you'll ask them to pinch like this over all of their fingers. But then once you see that they can do it on their own, you'll have them go here, and then you as the clinician will come in and you're gonna pull. And if they give way, they can't hold that, then we're looking at some weakness that's happening, and there is a pathology going on. Then we move into neurologic tests. Again, like the shoulder, we use isometric muscle testing to test the myotomes in the upper extremity. They are the same as the shoulder, so you can go over those. Then we're looking at the brachioradialis reflex, and so you'll hold the patient. Here, I'll hold my patient again. Brachioradialis is on the thumb side, and so they'll be thumb up, and you will tap the reflex hammer right in this area, and then what you're going to get is a reflex coming up this way. And then on the slide you also see the cutaneous patterns, and you'll use Q-tips to feel in these different cutaneous patterns to see if there's a difference on each side. So the last slide, again, we're not going to go over a ton of rehab because it gets very, very repetitive. So this one I thought would be really important, signs and symptoms that will require a referral. So possible epiphyseal or apophyseal injury, adolescence, tingling or numbness in the forearm or hand, an obvious deformity, excessive joint swelling, aside from the olecranon process, that olecranon bursitis, significantly limited range of motion, weakness in a myotome, gross joint instability, abnormal or absent reflexes, and then absent or weak pulse. If any of those are occurring in the upper extremity when you're doing any of these assessments, those are an automatic referral to the physician. All right, so that's what I have for elbow and forearm. I'll come back in and do wrist and hand in a little bit, and so then you guys have all of those together. If you have any questions, let me know. Again, you only need to do one injury for elbow, forearm, wrist, and hand. So one for all of those together, not one for each video here. And then those will be due next Wednesday. So you have a week to do one injury for the upper arm, elbow, forearm, wrist, and hand. If you have any questions, email me and let me know.